Good afternoon, colleagues, friends. It's a great pleasure to welcome you to this webinar, which is co-hosted by the South African Medical Research Council and the Department of Psychiatry at the University of KwaZulu-Natal. This afternoon's webinar will be co-facilitated by me and Professor Bonga Chalise, who's the chair of the Department of Psychiatry at UKZN. Colleagues, it gives me great pleasure to welcome you and to welcome Golam and to introduce him to you. He is one of the world's 4 leading experts on the immune system and its role in psychiatric illness. I don't want to take too much of his time by introducing him, but by way of introduction, I do want to say just a few things. That Golam is a psychiatrist who still finds time to see patients. He's the professor of Psychiatry and Immunology at the University of Bristol. He's edited textbooks on immunopsychiatry and is on the editorial board of at least 2 prestigious journals. Golam, it's a great pleasure to have you with us this afternoon, and we really look forward to hearing your thoughts. Thank you.
Thank you, Jason, for the kind introduction, and also for you and Bonga for inviting me to talk at this seminar today. I will bring my slides up. Yep. So, as you may have seen in the flyer, the title of my talk is The Immune System's Role in Depression and Schizophrenia, thinking about mechanism and what that tells us about developing new treatments. So, just an overview of what I will cover in the next 40-45 minutes. We will start with thinking about a few common myths in neuroscience and whether they are still relevant for understanding health and disease, or should we get rid of them? I will briefly mention what we mean by inflammation in the context of chronic disease. Thinking about the link between inflammation and depression and other psychiatric conditions, I will share some new and important data, particularly around the question of causality and disease subtyping, ending with a few thoughts about the current state of research into translation of these findings to inform better ways for treating people with mental illness. As Jason mentioned, in our group, as well as translational work, we do a lot of work understanding what determines immune response, genetic and environmental influences of immune response. But for sake of time and considering the mainly clinical audience, I will not go into those areas in my talk in too much detail today. Starting with myth number 1. Something that has been around for several centuries, the idea of mind-body dualism, that our body and mind are distinct entities, completely separate from one another. It is so prevalent in our psyche that in the country where I work, in the United Kingdom, our physical and mental health care is provided in different hospitals by different organizations. It not only shapes the way we think about causes and mechanisms for psychiatric or brain conditions, but this is an example how it shows how we organize healthcare at national level. Over the last 30 years, we have now several examples from clinical medicine showing that why we should now move beyond this dogma. I will show you one. This is a story of multiple sclerosis. When I went to medical school in 1990s, we knew multiple sclerosis to be a purely neurological condition of fairly unknown cause. The field has moved rapidly over the last 3 decades. We now know it's underpinned primarily by dysfunctional immune response, and some of the treatments now form the mainstay of treating people with multiple sclerosis are immunotherapies. So here is a condition that within our lifetime has been completely reformulated from a brain condition to an immune-mediated neurological condition where the interplay between the body and the brain and the mind plays a vital role. The second myth is blood-brain barrier. In medical school, we were taught that the brain is shielded behind a Berlin Wall, so-called blood-brain barrier, that protects the brain from anything that is immunologically harmful. So that is protein, antibodies, bugs in our systemic circulation. We now know that there is a great deal of crosstalk between our brain and body's immune responses. Our systemic inflammatory response has a strong influence on our mood and cognition. This figure shows a number of pathways through which systemic immune system, so immune response in our body, can communicate with the brain and influence neuronal function, survival mechanism. Blood-brain barrier clearly seems to be a misnomer. It would be probably best named as blood-brain interface. Third one, somewhat closer to home in psychiatry. We tend to work with uniform or single explanation for what seems to be pretty obvious, complex heterogeneous syndromes. So here we have in front of us symptoms of depression that clinicians use day in and day out to establish ICD-10 diagnosis of depression. I've simply coded the so-called somatic symptoms in green and the other symptoms in black. And we have the core symptoms on top and additional symptoms afterwards. And you clinicians would know that to meet the criteria for ICD-10 criteria for depression, an individual has to have 2 out of the 3 core symptoms and 2 out of the other additional symptoms for 2 weeks to meet the criteria. Now, a quick mental exercise, if we take 2 out of 3 and 2 out of 13 here each time, how many unique combination of symptoms are possible, all meeting the criteria for depression? It's more than 200 combinations. The point I'm making here, that there is extreme phenotypic heterogeneity within depression. So simple unifying theories, serotonergic dysfunction, may be too simplistic and doesn't quite cover the entire breadth of clinical presentation we see in clinic. So before we move on to talking about links between immune response and depression, I want to clarify what we mean by inflammation in the context of psychiatric or chronic disease more broadly. When we talk about inflammation, what we refer to is low-grade systemic inflammation, which is the product of our innate immune response. It's mediated by inflammatory proteins such as acute phase proteins like CRP, for example, and cytokines such as TNF, interleukin-6, and other proteins that are secreted by lymphoid and myeloid cells. One way to conceptualize these immune proteins, they're conceptually the same, they play the same role for immune system as neurotransmitters do for the nervous system. In an acute infection, we see a rapid and massive increase in concentration of these proteins in blood, often 10 to 100-fold, depending on the severity of infection. And that is mirrored with so-called cardinal signs of inflammation or infection, so pain, redness, swelling, loss of function, and so on. Low-grade systemic inflammation is qualitatively and quantitatively different. Here, there is measurable increase in concentration of these proteins, but the magnitude of increase is much lower, sometimes 2, 3, 4, 10-fold. So few-fold increase, and this inflammation is silent. We do not see cardinal signs of inflammation in patients, fever, and such like. So here are some of the key proteins that have been studied extensively in the context of depression, cardiovascular disease, and other illnesses where low-grade systemic inflammation has been implicated. As well as infection, we now know that a number of other factors can activate our innate immune response. These include exposure to violence, trauma, psychological stress more broadly, obesity, sedentary lifestyle, calorie-rich, fatty, and diet. And some of you know that these are already some of these are established risk factors for psychiatric conditions like depression. What happens when our systemic immune response or signal reaches the brain? These are a couple of reviews worth reading that summarizes various pathways through which our body's immune response talks to our brain central immune machinery. A number of things happen at molecular level when the signal reaches the brain. At neurotransmitter level, there is decrease in production of serotonin, increase in production of glutamate and oxidative stress, increase in concentration of reactive oxygen and nitrogen species, leading to excitotoxicity and decrease in neurotrophic support, as reflected by decrease in concentrations of BDNF and other trophic factors. So you can immediately think how these biochemical changes are relevant for some of the symptoms that we see in psychiatric patients in clinic, such as problems with mood, perception, and cognition that cuts across different psychiatric syndromes from depression, schizophrenia, and other conditions. So now I will show you some of the key evidence linking immune dysfunction or inflammation with depression from humans. There is a whole host of work in healthy volunteers and in animal models. The data I will be showing here mainly focuses on patient samples, human patient studies. It is well established that immune activation leads to depressive symptoms. One of the earliest observations is the fact that patients with hepatitis C who are treated with interferon, about 50% of them develop major depressive disorder. This is one of the earliest clues that if we activate our systemic immune response, some people develop depression as a side effect. Recent work shows that even mild degree of immune activation using milder stimulus, such as typhoid vaccine, is enough to induce measurable changes in mood and cognition in healthy human volunteers. The second line of evidence comes from neuroimaging studies. So neuroimaging PET studies looking at microglia activation between people with depression and non-depressed control consistently shows that patients with depression have increased levels of microglia activation, indicating neuroinflammation. So microglia is the resident immune cells in the brain, indicating evidence of neuroinflammation in people who are acutely depressed. The third line of evidence comes from looking at immune cells in blood and comparing them between people with depression and controls. And these studies show that acute depression is associated with changes in a number of immune cell subsets, both myeloid and lymphoid cells, including T and B lymphocytes, neutrophils, and monocyte. The changes in B lymphocyte as well as T lymphocyte and other cells is particularly interesting because that clearly points to the fact that depression is associated with changes not only in innate immune response, but also our adaptive immune response. Finally, I'll show you some meta-analyses comparing inflammatory protein concentration in plasma in people with depression, schizophrenia, and bipolar disorder, compared these with controls. And largely, these studies show that these psychiatric conditions are associated with increase in concentration of circulating immune proteins such as IL-6, TNF, and interferon, and decrease in anti-inflammatory proteins such as IL-10. There are studies that have assayed this protein in samples that are anatomically closer to the brain, that is CSF, and very similar signal. in patients with schizophrenia, bipolar disorder, and depression, there is increased concentration of pro-inflammatory cytokines such as IL-6, IL-1 beta in cerebrospinal fluid compared to controls. So while these findings suggest that there is an inactivation of innate immune response in people with major psychiatric disorders, particularly depression and psychosis, there are key unanswered questions. Number one, in my head, is the issue of causality. Is the association causal, or could this be explained by reverse causation or confounding? Reverse causation is a real possibility. I mean, I've told you it is possible that inflammation is a consequence of illness rather than be its cause. I've told you that psychological stress can activate innate immune response, and you don't have to be a psychiatrist to know that depression or psychosis are extremely psychologically stressful conditions to have. Confounding is another possibility. It's possible the association between inflammatory proteins and psychiatric conditions are confounded by certain socio-demographic, diet, lifestyle, or other factors. Second is the issue of treatment. And that's closely linked with the issue of causality. If immunological proteins are pathways, if they are causal, could we use them as treatment targets for developing new treatments, both pharmacological and non-pharmacological? And if so, which proteins or pathways should we prioritize? And third, is inflammation relevant for everybody with depression or psychosis, or is there a subgroup? Are there patients where treatment more likely to be beneficial? So idea of precision or personalized medicine. So I'll start with showing some data around the issue of causality. To address the chicken and egg problem, what comes first, we did some work using longitudinal data from a birth cohort from southwest of England. It's called the Avon longitudinal study of parents and children. So here, in about 5,000 children, plasma samples were assayed. This blood was taken when they were 9 years old for IL-6 and CRP, two archetypal inflammatory proteins. Fast forward 9 years, the cohort was assessed for psychiatric outcomes, and we established diagnosis of depression, psychotic disorder, and also psychotic symptoms. And as you can see, the graph simply shows cases of depression in blue, psychotic symptoms in amber, and psychotic disorder in red, grouped by level of IL-6 in childhood. And as you can see, there is a clear dose-response association between childhood IL-6 levels and subsequent depression and psychotic symptoms subsequently in early adulthood. And these associations remain after controlling for a number of possible confounders, including family history of mental illness, sex, age, body mass index, and psychological and behavioral problem preceding the measurement of IL-6, suggesting that there is a longitudinal association between higher levels of inflammatory markers at T1 and increased risk of depression and psychosis at follow-up at T2. So this is one of the first human epidemiological studies showing a longitudinal association between inflammation and depression and psychosis, suggesting that inflammation could be a cause for these conditions rather than simply be a consequence. These findings have been replicated in other samples. So this is a study using data from a Finnish cohort. This is data using a study using data from a Swedish cohort. And this is a study using data from a Dutch cohort. And this is independent replication by a group in University College London. And broadly, there are other examples now, and broadly they show there is evidence for a longitudinal association. What about confounding? So that is another possible explanation. So to assess the issue of confounding more carefully, we have used a genetic method called Mendelian randomization. It's a causal inference method that uses genetic variants for immunological proteins. In this context, we have used genetic variants regulating levels or activity of immune proteins as proxies to assess whether the association between immunological proteins and depression is likely to be causal. For sake of time, I won't go too much into methodological detail, but I would recommend this paper in Nature Reviews Methods Primer by my colleague Eleanor Sanderson, who beautifully explains the method and its use. This is a recent example how Mendelian randomization has been used to provide evidence that interleukin 6 plays a causal role in COVID-19 induced pneumonia. And we now know that tocilizumab, monoclonal antibody that blocks IL-6 signaling, is now licensed and used widely for treating people with severe COVID. So this is a very good illustration of how human genetics can help us strengthen evidence of causality and help identify and develop new treatments. We have used this study design to examine the relationship of cardiometabolic risk factors on depression. The question is, are these factors related to a causally influenced risk of depression? And out of about 20 cardiometabolic risk factors we assessed, after correcting for multiple testing, we find evidence of a possible causal effect of 3 biomarkers on depression: 1 lipid, triglycerides, and 2 inflammatory proteins, interleukin 6 and CRP. Again, implicating immunological and metabolic dysfunction, possibly a causal driver for depression. Recently, we have taken advantage of large-scale proteomics data from UK Biobank to look at relationship between immune response-related proteins and a number of neuropsychiatric conditions. So this is the largest study of immune response-related proteins and neuropsychiatric conditions to date, to my knowledge. We have looked at 735 immune response-related proteins. That is all such proteins currently measurable in human plasma. We have assessed their effects on 7 psychiatric outcomes: autism, ADHD, anxiety, depression, bipolar disorder, schizophrenia, and Alzheimer's disease. We had a systematic 4-step approach. So first, we used Mendelian randomization to test whether the proteins have a causal effect on the outcome, the conditions. The second, we tested this relationship in the reverse direction, whether the condition, so depression, has a causal effect on an immunological protein, because we felt the direction of association is fundamental. Second, we used another genetic method called genetic colocalization that helps us identify whether a particular immunological protein and a psychiatric condition share a causal gene. So that's important, because if we do find that there is protein X is related to schizophrenia, we wanted to know that this is simply not because of the case that these are caused by a shared gene. And the fourth, we identified whether any of the causal biomarkers that we find are these druggable. So could these be used in future clinical trials using drugs that are already approved or in advanced development in phase 3 trial for any indication? So long story short, here you were looking at the graphs for schizophrenia and depression. And as you can see, after correction for multiple testing, we see a number of immune proteins that have strong evidence for a causal effect on schizophrenia and depression, including proteins like CD40, angiotensin converting enzyme, and TNF. We find, compared to schizophrenia, fewer proteins for depression, but the proteins that we find are particularly involved in interferon signaling. Again, that corroborates the old clinical observation that interferon induces depression. We also identified shared mechanism for neuropsychiatric conditions. We find that CD40 plays a causal role for both 2 psychotic disorders, bipolar disorder and schizophrenia, And ACE plays a causal role in two conditions where cognitive dysfunction is a prominent feature: Alzheimer's disease and schizophrenia. So in total, we've identified potential causal role for 21 biomarkers, and at present, 18 of these are potentially druggable. This paper has been pre-printed, currently under review. You can read this in medRxiv. So moving on to changing gear into, is inflammation relevant for everybody, or are we talking about a subtype of individuals with depression or psychosis? Systematic review and meta-analysis of patients with depression show that evidence of inflammation is present in a subgroup of patients with depression. So here, Emmanuel Osimo from my group shows that inflammation defined as CRP, low-grade inflammation, defined as CRP more than 3 milligram per liter, is present in about 1 in 4 people with depression. So it's present in some people with depression, not everyone. So we are not suggesting a be-all and end-all explanation for depression. This is a study in collaboration with colleagues in the Netherlands. And here we looked one step deeper from syndrome level. So we looked at effect of immunological proteins, IL-6 and CRP, on individual depressive and anxiety symptoms. And this work shows there is a great deal of heterogeneity with regards to the effect of immunological proteins on individual depressive and anxiety symptoms. They are more strongly related to so-called somatic symptoms of depression, such as fatigue, sleep problem, rather than the so-called psychological symptoms of depression, such as hopelessness, excessive or inappropriate guilt, and so on. Here is some really recent work from the ULSPAC Barth cohort from southwest of England, from the city of Bristol, where I live and work, where we have tried to understand that can we make use of this heterogeneity to identify biology-based subtypes of depression. Because I've started this talk by telling you that, and you clinicians, you already know that depression is an extremely clinically heterogeneous condition. Same goes for psychosis. In fact, other than schizophrenia, every single condition in psychiatric textbook are syndromes. So here, I'm showing you the correlation matrix for depressive and anxiety symptoms and about 110 immunometabolic biomarkers. I know you can't read it, but that's not necessary. The main point is, do we see any pattern? And as you can see from the heat map, there is a clear pattern of areas in red and areas in blue showing that certain symptoms are positively correlated with immunometabolic biomarkers and others are negatively correlated with immunometabolic biomarkers. And when we try to look for clusters within this data using symptoms and immunometabolic blood biomarkers, we see people with depression can be classed into two groups. One is somatic and low mood symptoms group, and the other one is more anxious and cognitive dysfunction group. And these groups seem to be different also with regards to their immunometabolic association. So the somatic and low mood group have changes in classical inflammatory proteins, such markers such as IL-6, WBC count, neutrophil count, whereas the anxious cognitive group have problems related mainly, biochemical changes mainly to liver-related enzymes. There is also a difference between these two groups with regards to prognosis. So here, this graph at the bottom is showing you depressive symptom severity score in the 5 years follow-up. So this data is based on individuals who are about 24, 25 years old. So we have data from yearly follow-up for 5 years, from 25 to 30. And as you can see on the left, the somatic low group, they have persistently high depressive symptom scores in 5 years follow-up, much higher than the other group. This suggests that we may be able to use immunometabolic biomarkers along with clinical information like symptoms and other factors to derive subtypes of depression that are clinically relevant. Staying with the theme of clinical relevance, for the last 10 minutes, I would like to talk about clinical relevance. And here, by clinical relevance, I really mean clinical relevance, treatment potential. So we know that inflammation matters. It's a clinically relevant phenotype. It's directly linked to poor response to current treatment, let it be antidepressant medication, psychotherapy, or antipsychotic treatment. I'll show you a couple of examples. So, two studies, one based on people with first episode psychosis, showing that patients with first episode psychosis that have higher levels of inflammatory proteins such as IL-6, interferon gamma at first presentation, they're less likely to respond to antipsychotic treatment. The second one, and below, is a study based on people with depression. Again, they show immune activation, so having increased levels of inflammatory proteins in blood at presentation is associated with poor response to conventional antidepressants. So if that is the case, could anti-inflammatory drugs help improve symptoms of depression and psychosis? A number of randomized controlled trials have been done where anti-inflammatory drugs have been given as add-on treatment to standard treatment, or in some cases as monotherapy. So this is a meta-analysis of these trials in depression, and together they show that adding anti-inflammatory drugs, this meta-analysis combines data from non-steroidal anti-inflammatory drugs to more specific anti-cytokine drugs, but nonetheless, they're all anti-inflammatory drugs of different kinds. They show that they improve depressive symptoms more than antidepressants alone. Here is a study we did looking at anti-cytokine drugs. Our interest in particular was because anti-cytokine drugs are very specific with regards to their mechanism of action, unlike non-steroidal anti-inflammatory drugs, where we are probably thinking it's due to anti-inflammatory effect, but they are broad spectrum, so we can't 100% pin down the effect is due to changes in inflammatory pathways exclusively. But these drugs, we know that these are newer biologics like anti-TNF, anti-IL-6 drugs used in rheumatoid arthritis, psoriasis, and other inflammatory bowel disease, and so on. And we know these drugs block those particular proteins and leave the rest of the immune pathways alone. So we know that here, any therapeutic effect can be confidently attributed to the effect on that protein. These studies also show very similar effect. We find that there are anti-inflammatory drugs that block cytokine pathways have a noticeable impact on depressive symptom. We subsequently also show this is simply not because people's physical illnesses are better. We show that improvement in depressive symptoms from anti-cytokine drugs is independent of improvement in physical illness. The last one is meta-analysis in patients with psychosis. As you can see, that anti-inflammatory drugs leads to a reduction in total symptom score. And when you break it down, we see a greater effect on negative symptoms and a smaller effect on positive symptoms of psychosis. For those who are not clinicians in the audience, so psychotic symptoms are broadly conceptualized as positive and negative, positive symptoms being the symptoms that people think of when we think of schizophrenia, so hallucinations and delusions and so on. And negative symptoms are less talked about, but hard to treat. These are anhedonia, social withdrawal, and so on. Which patients may benefit from immunotherapy? This is a fundamental question because I mentioned that inflammation and immune dysfunction is not relevant for everyone with depression or psychosis. Recent trials show that there is a correlation between the degree of inflammation at baseline and response to anti-inflammatory treatment in patients with depression, it kind of makes sense that anti-inflammatory drugs are unlikely to be helpful in people with depression or psychosis, those who do not have any evidence of inflammation or immune dysfunction. And higher inflammatory activations that there is, the more greater chances of benefit from these medications. These are a couple of examples, proofs the negative. They show that giving anti-inflammatory drugs to anybody with depression doesn't help. So we need to be careful about who to target treatment towards. I mean, I must stress the field hasn't moved towards licensing of any of these medications for psychiatric patients just yet. So I would like to hold horses, and what I'm speaking to is the research that is needed and the type of research and the way we need to design these trials. So patient selection being the most important issue. Bearing this in mind, we are recently completed one trial of tocilizumab anti-IL-6 monoclonal antibody in patients with depression, and we're doing currently another trial of the same drug in patients with psychosis, where the primary outcome is negative symptoms of psychosis. And based on what we know, we have been very particular about selecting patients. Patients have to meet criteria for depression for the INSIGHT study. They have to have evidence of inflammation, so CRP tested twice, and they had to be over a certain threshold, and patients also have to have inflammation-related symptoms, so somatic symptoms. So these are inflammation-related factors we believe would maximize us finding or honing on that subgroup of individuals that are likely to benefit from immunotherapy. One study by colleagues in King's College London here, they have recently completed this trial of minocycline in patients with depression, and showing a very similar strategy to ours, where they had selected patients based on CRP levels, show that minocycline is a tetracyclic antibiotic drug that improves symptoms of depression in elderly individuals with depression and low-grade inflammation. So thinking ahead into the future, before these findings can be implemented in clinical practice, there are three fundamental questions we need to answer. And one is, the need is clear. We need large-scale phase 3 trials. And for those, we need to think carefully about the right target, which pathway we are targeting. And of course, there needs to be evidence from population, genetic, and other study design supporting evidence of a causal role of that protein or pathway in the condition. Second is the right patient. These are heterogeneous syndromes. The same treatment is unlikely to be helpful for everybody. So selecting patients where treatment is likely to be helpful based on existing knowledge and research is fundamentally important. And the third is the right outcome. Which clinical outcomes we expect to be improved by these new treatments. So I'll summarize so we have some time for discussion. So far what I've said, that clinical, neuroimaging, blood-based, and genetic studies provide strong evidence that inflammation could play a causal role in depression and psychosis. Evidence of inflammation is present in at least a quarter of patients. And the immunological proteins and pathways could represent new treatment targets for neuropsychiatric conditions such as depression, schizophrenia, and bipolar disorder. Immunological and metabolic biomarkers, alongside routine clinical information, would be useful for developing biology-based subtyping of depression. I showed you an example of such work in our group right now. Based on the existing randomized control trial, it seems that anti-inflammatory drug add-on treatment, such as non-steroidals or also anti-cytokine biologics, improve symptoms of depression and schizophrenia? If you want to take one take-home message from this lecture, it's this. Inflammation is relevant for some people with depression or schizophrenia, not everyone. This is not a universal mechanism for everybody with depression or psychosis. The success of large-scale randomized controlled trials that we need to provide definitive evidence of treatment effectiveness in patients, that would depend on clearer understanding of causal mechanism so we can choose the right target. So the genetic evidence that I showed earlier, Mendelian randomization, co-localization, etc., speaks directly to that problem. And the second is we also need to identify patient subgroups that are likely to benefit from such treatment. So that is about identifying inflammation-related subgroups so we can, to help us stratify patients effectively in RCTs. I mean, many of you would know these strategies may sound new to mental health, but old when we zoom out of psychiatry and think of medicine more broadly. In my medical career, cancer has moved from one cocktail of chemotherapy for every lung cancer patient that I used to manage as a resident in 1990s. Now, the treatment is very targeted based on genetic and other makeup. And this is the work that we need to do to make similar kind of advance in mental health today. Finally, I'd like to thank my group. The work I've presented today is the result of a number of people you can see on the screen. I'd like to thank my funder and you all in South Africa Medical Research Council and UKZN for dialing in and listening to my talk after a very long day at your work. Thank you very much. I think we have about 15 minutes for questions.
Sure. Thank you so much, Prof. I don't even know where to start, and there's so many. What a wonderful wealth of information. I hope you can hear me. Golam?
We can hear you loudly, Golam.
Okay. I wanted to ask you a little bit about just a couple of things. Then, I also just want to ask colleagues to please send in questions. You can start sending questions. We've got a little bit of time. But I wanted to ask you a little bit about this issue of taking a few very well-defined people with a particular illness and doing multiple investigations on that cohort. So for example, genetics, brain imaging, CSF, immune and blood, CSF kind of markers, and seeing if would that kind of take us some way towards trying to work out these things, or do you honestly feel that large scale sort of collaborative studies is the way to go to try and kind of tease out, I guess in the end, we're all trying to, understand these illnesses better so that we could help them in terms of improving suffering and things like that. But I'm just wondering about in terms of approach, methodological approaches to these things. And of course, you eloquently kind of mentioned the large scale stuff, but I'm just wondering, what about colleagues who are shy and are sitting in a corner somewhere in South Africa or India saying, let's just take this one cohort and just really, really work hard. We have access to imaging, we've got genetics, we've got CSF. Would that also be a meaningful contribution towards this kind of area of work?
Thank you. A couple of things comes to mind. I mean, this is a very important issue you raise. A couple of things come to mind immediately. Number one is I completely agree with you on the need for large-scale collaborative study and evidence from different parts of the world, from different populations. So the data I've shown today largely comes from European and North American population. So there is a big need for data from Africa, Asia, and South America. And that's one. Second, and we know that some of these areas have the prevalence of infection inflammation is much more common than these populations where Alspec and other studies that I've showed you data from. Second is, what would a subtyping look like for clinical practice? So yes, it is true that the data that we are working on, these are deeply phenotyped cohort where using expensive and high throughput methods, various omics data have been generated like proteomics, genomics, and we are using them to understand disease subtyping. But I imagine the clinical picture, as and when this moves to valid and reliable subtypes, that would look very different. Because first and foremost, such methods for stratification or subtyping will have to be doable. I mean, high throughput omics assays are not doable in most hospital settings in the UK and in many parts of the world. So the process would look like this, in my view, that initially the studies would be looking at complex models. Subsequently, but once we have cracked it using such deep phenotype and multi-omic methods, we will be able to find, the next step would be finding surrogates for these markers that are reliable and easily measurable. And that means they're easily deployable in clinical practice. And there are examples of that has happened in other areas of medicine, for example, cancer. So, or even rheumatoid arthritis. Rheumatoid arthritis, although the drugs are targeting, for example, anti-TNF or anti-IL-6, they're targeting particular cytokines, and they've come to these drugs on the back of much genetic and clinical studies of the kind that I have described here. But you would know that the colleagues in hospital for making treatment decisions, whether to divert some of the body's treatment from a standard non-steroidal to disease-modifying agent to biologics, for that clinical decision-making is now used based on disease severity, very clinical measure, but inflammatory markers at the same time. And the inflammatory markers are pretty basic, ESR or CRP. So going from this complex omics to those more deployable and clinically usable parameters is a bridge, but there are examples in medicine where they have been able to bridge that gap. Otherwise, I agree with you. To me, as a clinician, what is the point of developing a method that can accurately classify a condition into 3 subtypes, but that can be only done in 2 highly specialized centers in London or America?
Yeah, thanks, Golam. There's a question here for you, but before I read that question, I wanted to ask you about your thoughts around anti-inflammatory properties of antipsychotics, for example. We know that there's some potentially anti-infective stuff, particularly with the older antipsychotics. And I was wondering if there's also a little bit of an overlap with that. And the question is about, can immune levels be used to monitor response to treatment? So just looking at some of these immune levels.
The first thing first about the anti-inflammatory properties of antipsychotic drugs. I mean, if you think about, I know you do a psychosis clinic. What is the most effective antipsychotic drug we have now? Based on systematic review and meta-analysis of dozens of randomized controlled trials, the first thing that comes to mind is clozapine.
Clozapine, yeah.
We know that this drug has very strong immunomodulatory effect, immunosuppression. So neutrophil and WBC count going down is a known side effect of this medication. So this is a classic example of an antipsychotic drug, very effective in treating psychosis, having very potent, strong anti-immunomodulatory effect. There are studies that have looked at anti-inflammatory properties of existing anti-cytokine drugs, and they show that some of these drugs do have anti-inflammatory properties, but what I'm not too sure about is the level of that anti-inflammatory effect. In clozapine, immunomodulatory effect is very obvious, but the effect is probably relatively small for some of the other drugs. Second question, part of your question was, can we use these anti-inflammatory or immunological proteins as a surrogates for treatment response? This is, again, an active area of research. So there are studies showing that with successful treatment, people who benefit from antipsychotic drugs or antidepressant drugs, there is a decrease in levels of inflammatory proteins. But patients who are treatment resistant, people who do not get better, there the immune activation persists. So these are the immune response is strongly correlated with response to conventional treatment.
Sure. And the other question is by a psychiatrist who's also done some pathology training prior to becoming a psychiatrist, Dr. Erickson. He's asking, has the role of microglial pathology been explored to be a possible biomarker?
That's a very good point. I mean, I didn't go too much into microglia. I mean, for those who without a background in immunology or pathology, I mean, microglia are resident immune cells in the brain. They come from the same myeloid origin, the monocytes and macrophages in our peripheral blood compartment. They come from the same lineage. In terms of volume, 5% of our brain is composed of microglia. Is roughly the same volume as neurons, basically. So microglia, there is a lot of work in terms of microglia morphology, what do they look like, and their function in psychosis and depression. There are some really good examples showing that in patients with psychosis, microglia, so these are, I'm thinking of studies that have used fibroblasts from patients with schizophrenia and induced them and then morph them into microglia cells. And they show morphological changes. They look different. The way they look different in particular, they show fewer branching of the cells. And also they produce excessive levels of proteins. So they tend to be, the concept that is talked about often is the idea of priming. So this cell seems to be primed for an exaggerated or heightened immune response when they're exposed to an inflammatory stimulus.
Sure. But I want to go back a little bit to the clinician. And so part of the things I think that was really interesting for us is the whole issue of stratification and I'm also wondering, even, you know, Max Birch, colleagues from Australia kind of popularized the staging model of psychosis. As you know, I'm particularly interested in psychosis. And I'm wondering do you think in 10 years or 15 years time, we'll find a way where you can combine biomarkers with some of the work that's already been done in kind of really thinking a little bit better about the so-called at-risk population. As you know, the clinical trials are for at-risk population to prevent, or delay onset of psychosis are very murky at the moment. They do require us to think a little bit more careful about it. So I guess the question is, how far are we from kind of putting in all the clinical stuff that we know, and then combining with with the biomarkers to kind of be able to better predict who is likely to develop, severe mental illness by the time they're 25 versus maybe, just regular teenage-related behaviors that we are at the moment all kind of lumping them as at risk.
That's a very good point. I mean, I very much like the concept of the staging model in psychosis that Pat McGorry and colleagues have introduced. I mean, this is a good way of conceptualizing in different stages, from at-risk to chronic and everything in between. The issue we have in reality is that these different stages don't really directly map onto in any clinically meaningful way in terms of who would benefit from treatment, who would progress or not. So that's where I see the limitations. in terms of where biomarkers could be useful. So there is one example from the Naples study done by Ty Cannons and colleagues in North America, where they looked at progression from at-risk mental state to first episode psychosis. And they studied, published some findings in biological psychiatry in the last 4 or 5 years, showing that, again, evidence of heightened immune activation or excessive inflammatory proteins at baseline was strongly related to progression from stage A to B, so at-risk mental state, to first episode psychosis. Where it's still not very usable for clinic is, of course, when you drill down to absolute positive predictive value of just the biomarkers, it's low. So my thinking is that, and I don't think I'm very different from many of the people in the field at the moment, is that biomarkers in combination with other factors are likely to be a better solution than just we're going to solve everything with genes or the neuroimaging or blood biomarkers. It probably will have to be a combination. And that's where I think working with colleagues like you, colleagues in SAMRC, and also elsewhere, generating clinical information, collecting clinical information and blood samples where possible from patient in a longitudinal manner. So at presentation, before and after treatment, in a longitudinal manner, we need more of those information to be able to then combine, like the example I was giving, the study that looked at interferon and IL-6 at baseline. It was a 3-month follow-up study of first episode psychosis patients, simply took bloods at baseline and at follow-up, measured clinical symptoms and treatment response at baseline and follow-up. And again, they were able to show that the inflammatory activation is related to poor response to treatment. So we need more of those information from multiple centers, including from colleagues in, and this would be, to me personally, a very an area of interest to collaborate on. And we have access to those clinics and patients in Bristol, for example, and to see, that would allow us not only to build this sort of predictive models, but then to validate them in other samples to see, yes, we've built a predictive model for progression in population A. How does that generalize to a sample in Durban or in Delhi?
I think, Golam, with that is probably a wonderful place to say thank you very much. We really, really appreciate what a fantastic tour de force that you've done. I don't know if Jason wants to say a last word, but that with that call for collaborations and thinking a little bit about how we further unpack these, perhaps is a good place to stop. And maybe I'll hand it back over to my friend Jason at SAMRC.
Thanks, Bonga. Thanks very much, Golam. I can only echo what Bonga said, and I hope that colleagues in the room will pick up some of these ideas and that they will lead to ongoing collaborations and the advancement of patient care. Colleagues, thank you very much for your time. Golam, thank you. Please look out for the next notice. We'll try and do another webinar in about 6 or 7 weeks' time. Take care, everyone.
Thank you very much.